into divisions, smaller and smaller, until reach to the arcuate artery, then the interlobular artery, which then divided into or developed the efferent arteriole inside the glomerulus. Then we have the efferent arterioles, capillaries, then it formed to the interlobular veins, arcuate vein, and then finally it ends with the renal vein. So there is a renal artery, enter the kidney, and renal vein go outside, and the divisions and the tributaries inside it, surrounding the functioning unit of the kidney, which is the nephron, in these details. Now, of course, you heard about the glomerular filtration rate. And simply to define it, because it is very important, and in the diagnosis and the assessment of the stage of the kidney disease, we depend on the GFR and on the creatinine clearance, of course. So it is defined as the flow rate of filtered fluid throughout the kidney. Flow rate through the filtered fluid through the kidney. And when we say rate, so it is measured by time. While the creatinine clearance rate, it is the volume of blood plasma that is cleared of creatinine per unit time. Of course, when we say rate, so it is time. And it is a useful measure for the approximating the GFR. So we have what's called the real GFR, and we have what's called the approximating or estimated GFR. We can assess the estimated GFR by knowing the creatinine clearance rate. We need this definitions, we need this terms, we need this units to be deal with while we are define and declassify and put a staging for the acute kidney injury and even for the chronic kidney disease. Now, according to the anatomy, according to the physiology, according to the blood supply of the kidney function is dependent on three factors, three parts, three steps. First, it is the adequacy of a blood supply to the kidney. We said it takes about 20% of the cardiac output. And here we talk about a prerenal factors or prerenal stage of the kidney function. Good adequacy or good perfusion of the kidney, it will be good function. Then integrity of renal parenchyma. This is talking about the kidney itself, about the nephrons itself, its ability to filtrate the water and solutes and the toxins and waste products. This is called the renal part. And the patency of urinary tract, which is called the post-renal. Post-renal, something related to the clearance of the waste product that pass out of the kidney, beyond the stage of the kidney. Now, we are reaching to the definition of the acute kidney injury. It is formerly called the acute renal failure, but nowadays, and in the recent years, they call it the acute kidney injury, which is more precise and more accurate definition. What is? Of course, it is a clinical syndrome in which a sudden deterioration in renal function results in the inability of the kidneys to maintain fluid and electrolyte homeostasis. We said the fluid and the electrolyte homeostasis, it is the principal, it is the main, it is the essential function of the kidney. So if there is a rapid deterioration, sudden deterioration within just a few days, this will lead to clinical syndrome called the acute kidney injury. Acute kidney injury, to put a criteria for the diagnosis and for the staging, in the world there is what is called the Kidney Disease Improving the Global Outcomes Organization, which is a global organization, non-profit of course, established in the United States, and now their headquarters found in Belgium. They put what is called the rifle criteria. Then they put what is called in 2012 pediatric rifle criteria, which is modified to meet the definition for the pediatrics. So what is the rifle? Rifle in English, it means the gun. In Arabic, البندقية الرشاشة. But rifle, it is an acronym for the stages of the kidney injury. So that's why we call injury, not failure. We will know how. The criteria rifle are, it refers for the risk, I for injury, F for failure, L for loss, and E for end stage. How we say this patient has injury or has failure or loss? This is according to parameters. The first, it is the estimated creatinine clearance. We say it is more powerful and helpful in assessment of the approximating GFR. And at the same time, we depend on other parameter, which is the urine output. So for example, for the risk, if the estimated creatinine clearance, and now the definition is clear for you, decreased by 25%, and the urine output is less than 0.5 ml per kg per hour for 8 hours, this is acute kidney risk. While the injury, if the estimated creatinine clearance decreased by 50%, and the urine output decreased in the same amount, but for 16 hours, reaching to the level of failure, real failure. This is here when the estimated CCL decreased by 75%, or according to the surface area, it is less than 35 ml per minute per 1.73 square meter. Or the urine output, it is less than 0.3 ml per kg per hour for 24 hours, or anuric. And we will know what is the definition of anuria. When we reach to the stage of loss and the stage, here we will not depend on the urine output, just on the estimated creatinine clearance. So if there is persistent failure, and we now know what is the failure. So persistent failure for more than 4 weeks, this is mean there is a loss. And the stage, it is when the persistent failure lasts more than 3 months. This is called the modified pediatric rifle criteria. But because the rifle focuses on the glomerular filtration rate and take the estimated creatinine clearance to give an idea about the approximated GFR. So there is what is called the Acute Kidney Injury Network, which is another association, a universal or global association, put a modification for this criteria to categorize the severity of the acute kidney injury depending on not the estimated creatinine clearance or the urine output, just on the serum creatinine. So they said, we can say this stage of acute kidney injury, it is stage 1 if there is 150% increase of the serum creatinine. This is mean 1.5-fold increase of the normal base serum creatinine. Stage 2, when the rise is more than 200%. This is meaning 2 folds and more. And the stage 3, when the rise in the serum creatinine, it is more than 300%, or in other words, it is more than 3 folds of the normal serum creatinine. This is how we define and how we put a staging and a classification for the acute kidney injury. Now we will go to talk about the epidemiology, or about the incidence of the acute kidney injury. It's occurring about 2 to 3% of children admitted to the pediatric tertiary care center. Like in our hospital, Al Zahra Teaching Hospital, especially we have a unit for the nephrology, for the hemodialysis, and for the peritoneal dialysis. So that's why we are tertiary center, and receiving cases of acute kidney injury comes directly to the hospital or referred from other hospitals or from other provinces. 8% of infants in the neonatal intensive care units, they have acute kidney injury. Whether they are premature baby, of course they are high-risk baby, critical baby, whether they are premature baby and their renal function is not mature leading to acute kidney injury, or they are complaining from other problems like the birth asphyxia, the hypoxic ischemic injury that could involve the kidney, causing the necrosis of the kidney tissue, or remember the mammalian diving reflex when the blood shifted away from the kidney, go to the brain, to the heart, to the adrenals, or they are undergoing the sepsis and its complication leading to acute kidney injury. The coexistence of acute kidney injury with the critical illnesses occur at rate 10%. Critical illnesses, as I said here, for example, in pediatric intensive care unit or neonatal, like in birth asphyxia or sepsis or prematurity. So the acute kidney injury has 50% mortality rate in children requiring dialysis. This is meaning some or certain ratio or percentage of those patients with acute kidney injury going toward the dialysis. 50% of them, they may be lost when they reach this level. Not because of dialysis, no. This is meaning because the level, it becomes so critical, it may cause 50% death among them. Now, the etiology. Because we took introduction and clarify the steps or the parts of the kidney, it may be prerenal, renal, and postrenal, depending on the function. So here is the same. We have prerenal causes related to something of the blood supply going inside the kidney. The kidney itself, it is normal, there's nothing with. Or it may be intrinsic or renal causes, or it may be post-renal, the adequacy of blood supply, the adequacy of renal function, but there is something facing the net product of the kidneys. This is called the post-renal. Now, we will start with the prerenal. It is called also prerenal anemia, the other term to describe the prerenal acute kidney injury or causes. Of course, here we have diminished effective circulating arterial volume. It will be less than the required, which is 20% of the cardiac output. And of course, time this will lead to inadequate renal perfusion and a decreased GFR. But with time, with short time, because we are talking about a sudden decrease, about acute insult. And as I said, in this type of causes, there is absence of evidence of kidney damage. The kidney itself, it is normal. And the renal function may return to normal. This is if we manage immediately and properly to correct the prerenal inadequacy of the blood volume or blood supply. But unfortunately, there is intrinsic renal parenchymal damage can develop if there is delay or improper management. The kidney itself will be involved with time. Going in the prerenal to talk about the causes. Of course, if I will ask you, the answer will be the dehydration. And the dehydration, of course, because of diarrhea and vomiting, or due to malnutrition or DKA, because the common is common. The other is hemorrhage. There is acute blood loss because of hemorrhage due to aortic or renal vessel injury or trauma. Sepsis and shock. Of course, sepsis and shock causing decreasing in the blood supply going inside the kidney. Hypovolemia, but not because of GI loss, with capillary leak syndrome or what's called the nephrotic syndrome, causing edema, interstitial edema, and causing decrease in the intravascular volume. Heart failure, of course, because the pumping of the blood to the outside of the heart, it is failed, it is impaired, so there is no efficient cardiac output. Burn, because there is a translocation of the fluids. So these are the group of the prerenal causes. If we go to the renal, to the intrinsic causes of the acute kidney injury, so renal parenchymal damage, and here includes sustained hypoperfusion and ischemia. If you remember hypoperfusion, if it is for short time, reversible or managed properly and immediately, it will lead to the correction and there will be no involvement of renal parenchyma. But if it is sustained, it will lead to intrinsic with time. Ischemia, as example, as I said, the hypoxic ischemic injury and the birth asphyxia involving the kidney. So this is the principle of the intrinsic. The causes, glomerulonephritis, because the nephron is involved by the process. Hemolytic uremic syndrome, I will discuss it in details. Acute tubular necrosis, the example what happened in the birth asphyxia. Nephrotoxins, medications, other MAB nephrotoxins affecting on the renal parenchyma, renal vein thrombosis. We are talking renal vein. So inside the kidney, rhabdomyolysis, excessive muscle exertion affecting on the renal parenchyma and its function. Acute interstitial nephritis, tumor infiltration, of course, affecting on the functioning units of the kidney, and the tumor lysis syndrome after taking chemotherapy, also affecting on the function of the intrinsic function of the kidney. If we talk about the acute tubular necrosis and its mechanism, so it is seen most often in critical ill infants and children. The example, as I said, it is the hypoxic ischemic injury or in sepsis. And this is usually resulted from severe and prolonged hypoxic ischemia and nephrotoxic insult, like taking medications, contrast study, causing a bad nephrotoxic insult on the kidney. The mechanism of the intrinsic in general, not just the acute tubular necrosis, intrinsic or the parenchymal or renal causes talking about the post-renal causes of acute kidney injury. Post-renal, as we said, it is about something outside, beyond the kidney. Of course, the commonest cause in pediatric, it is the posterior urethral valve, or it may be uretropelvic junction obstruction, or they call it the UPJ or a JPU obstruction. The uretrovesicular junction obstruction, the urethrocoel, bladder, urethrolythiasis, hemorrhagic cystitis. All these are post-renal causes. Neurogenic bladder, affecting on the evacuation of the bladder. But what is good in post-renal causes? The obstruction must be bilateral to result in acute kidney injury, because if it affects just one kidney and the other functioning, so there is no acute kidney injury. But if it is bilateral, so that's why we put the posterior urethral valve on the top of the list. I will repeat it. It is something outside of the kidney, beyond the level of the kidney, starting from the ureter or from the pelvis of the kidney to the urethra. So we put posterior urethral valve because in the post-renal, the obstruction should be bilateral to cause acute kidney injury. Unilateral, the other function of the kidney will be preserved of the other side, so it not result. And what is good also in post-renal causes, it is the relief of the obstruction will correct the condition, will result in recovery of renal function. Now, these are called the stages of the or phases of the acute kidney injury. Starting, this is the GFR, if you see here, and this is starting from the decreasing in the GFR in prerenal. The phases, it will be phase of inflation, then extension, then there will be maintenance on the low level of the GFR, then with time there will be recovery. If you see here the dotted arrows, this is meaning at each phase of the kidney, if there is early and proper intervention, it will correct the insult, the acute insult, leading to recovery. So it may be with just the prerenal, in a few days or at the time of the happening of the prerenal, like in dehydration, and you correct the dehydration, so there will be recovery before going to the acute kidney injury to be manifested clearly. And all these processes, if you see, take just a few days because we are talking about acute kidney injury. But we have clinical stages of acute kidney injury. The clinical stages, this is depending on the amount of urine output. So we have the initiating phase. In initiating phase, it is the time of insult until the sign and symptoms become apparent. And we will know what is the first sign and regarded the hallmark of the acute kidney injury, which is decrease in urine output. Then we go in the oliguric phase. In oliguric phase, of course, there's decrease of the urine output. And this is usually appears in the 1 to the first 7 days of life of initiating phase. If there is no intervention, if there is no correction, the patient will undergo into the diuretic phase. Here, usually started within 10 to 20 days of the onset of the oliguric phase. And finally, there is the recovery. We are talking about acute kidney injury, so we should put the recovery of the condition as the ultimate result or fate of the problem. What happened to be chronic, this is the unexpected. So the recovery usually become total or in the 1 month, and it may take up to 12 months, and according to the causes of the acute kidney injury. Now, the clinical manifestations. As I said, the hallmark is decreased urine output. But the clinical features may range from symptomatic with mild to moderate elevation in blood urea and serum creatinine to anuric, not just oliguric, renal failure. So there may be decreased urine output, which is the hallmark, as I said, fluid overload, hypertension, uremia. I mean, the uremic encephalopathy, development of seizure, or disturbed level of consciousness, electrolyte disturbances. And if I ask you, the answer will be firstly on top of list, it is the hyperkalemia and the hypocalcemia. So what is oliguria? We heard and we repeated more than one time in this lecture. The definition of oliguria, it is urine output that is less than 1 ml per kg per hour in infants and less than 0.5 ml per kg per hour in children, or less than 400 or 500 ml per 24 hour in adults. So the definition is according to age group. There is no one definition for oliguria. While anuria, when the urine output is less than 50 ml per day, regardless of the age group. This is the oliguria and this is the anuria. You have to know it, you have to keep it in your mind. Now, how we diagnose patient with acute kidney injury? Of course, starting with history, because according to the history, we can detect or determine the primary cause for this acute kidney injury or insult. So, history of acute vomiting and diarrhea goes with prerenal acute kidney injury. History of diarrhea with pallor and petechiae, such as the hemolytic uremic syndrome, especially if it is bloody diarrhea. History of recent pharyngitis within the last 2 weeks or more, present with periorbital swelling edema, with hypertension, a gross hematuria by general urine. This goes with the acute post-streptococcal glomerulonephritis, and this is meaning intrinsic acute kidney injury. The same in HUS. History of protracted hypotension, like in a critically ill child with exposure to nephrotoxic medications, also have the patient most likely to have the acute tubular necrosis. History of neonatal hydronephrosis, baby, neonate, prenatal ultrasound, there is a hydronephrosis or palpable ladder. Of course, we are talking about obstructive uropathy or congenital urinary tract obstruction. So the history is very important. Going to physical examination is also because the careful attention should be go toward the volume status. Your patient is hypovolemic, eovolemic, or hypervolemic. There are signs of fluid overload, like edema, peripheral edema, heart failure, pulmonary edema, pleural effusion. All these are signs of fluid overload. So signs of severe dehydration, hypovolemia, suggest inadequate circulating volume. And you put the possibility of acute kidney injury, which is the most common. We see in an emergency department daily. Correct the dehydration, the prerenal acute kidney injury will be corrected itself on its own. Hypertension, peripheral edema, rales or crackles, cardiac gallop, of course, these are signs of volume overload, that's it. And there's increased possibility of intrinsic acute kidney injury, either from glomerulonephritis or acute tubular necrosis. Presence of rash and arthritis also indicate intrinsic, like in SLE, inoxion line purpura nephritis. Palpable flank mask may be seen with renal vein thrombosis and tumor and cystic disease or an obstructive uropathy. Hydronephrosis, this is meaning. Now the investigation very important because no diagnosis of acute kidney injury without doing investigation. CBC important. Why? Because the patient, they have anemia, maybe delusional or hemolytic anemia, there's leukopenia and thrombocytopenia also. So it may be pancytopenia. Hyponatremia, and mainly it is delusional because of fluid overload. Metabolic acidosis, and the metabolic acidosis because the retention of the hydrogen ion because of the impaired kidney function, so lead to metabolic acidosis. Increase blood urea, of course, serum creatinine, and according to the faults, we know which stage we are. Uric acid, the potassium, we have hyperkalemia, hyperphosphatemia, and hypocalcemia. So the calcium decrease and the phosphate increase. Decrease in the complement, C3, we can see it in post-infectious glomerulonephritis, in SLE, or in membranoproliferative glomerulonephritis. ASO titer, this is increased in acute post-streptococcal or and the anti-nuclear antibody in SLA nephritis. General urine is also important in investigation because we can see gross hematuria or microscopical, proteinuria, RBC or granular CAS can see in the intrinsic, especially the glomerulonephritis, whatever the cause, and the acute tubular necrosis. Urinary indices is also important regarding the sodium, the osmolality, the specific gravity. So this differentiate between the prerenal and renal if there is a changes of these parameters if you see in this table. Ultrasound important because if there is hydronephrosis or hydroureter or nephromegaly, this means obstructive uropathy. Chest radiograph to see if there is heart failure, pulmonary congestion, pulmonary edema, or pleural effusion, signs of overload. Renal biopsy can ultimately be required to determine the precise cause of the acute kidney injury. This is not used usually. The promising acute kidney injury biomarkers include changes in plasma neutrophil. This is called promising. So in the future, they talk about its validity in detection of the acute kidney injury, even in the early or initiating phase of the insult. Treatment is very important. Now we know the patient with acute kidney injury. He has imbalance of the fluid, maybe hypovolemia or maybe volume overload, and there is electrolyte disturbances, and there is metabolic acidosis, and there is hyperkalemia, and there is hypocalcemia. So the management is toward the correction of all these disturbances and abnormalities. Starting with medical treatment. We have two lines of a treatment. Either start with the medical treatment to correct all these abnormalities, or if there is failure, so we go to do the dialysis. So with medical treatment, we should know the goals. Maintenance of electrolyte and the fluid balance. avoidance of life-threatening complications, which are at the same time manifestation and complication of acute kidney injury. Adequate nutritional support. The patient should receive his nutritional requirement when he is in acute kidney injury. A treatment of underlying cause, because as we say in pre-renal and post-renal, treatment of underlying cause lead to correction without involvement of the kidney itself. Leaving it will lead to intrinsic or parenchymal kidney injury. What are the principles of the medical treatment? The pre-renal and post-renal factor should be excluded or corrected. We should know, and this is by history, by examination, and by investigation. The volume repletion. Your patient has dehydration, you should give a fluid. Stop offending nephrotoxic medication. You give some antibiotics or drugs that have nephrotoxic effect, you should stop it. And relieve the urinary tract obstruction. Put Foley catheter, overpass the obstruction by any surgical procedure to correct the primary problem. And in all cases, the effort should be made to limit the additional injuries. You have already renal injury. By these principles, you will prevent and avoid the additional. And the medication dosage should be adjusted or decreased. If you hear some medication, some antibiotics, we decrease the dose and we increase the frequency. Sorry, decrease the frequency or increase the time duration between the doses of the drug. This is one of the way to solve the effect of the drugs on bad effects on the impairing kidney, on an insulting kidney. How we treat by the fluid management. Determination of the volume status on initial evaluation. This is first, your patient hypovolemic or overload or hypovolemic. Strict measurement of input and output. So you should insert Foley catheter for real assessment of the urine output. And according to that, you will detect what is the input you should give to it. So if there is hypovolemia, we can give bolus of normal saline, 20 ml per kg, over 30 minutes. And the boluses may be repeated more than one time. And if the patient is hypovolemic, there is pre-renal causes. So he void within 2 hours. But if he failed to void, so this suggesting the intra-renal or the renal or post-renal causes of acute kidney injury. The patient may have hypotension because of sepsis or because hypovolemia. So vigorous fluid resuscitation followed by continuous infusion of norepinephrine to increase the cardiac output, to elevate the blood pressure. So there will be effective blood supply to the kidney. Going on the fluid management, diuretic therapy. You give a fluid, weigh the patient for void. So diuretic therapy should be considered only after the adequacy of circulating blood volume has been established. This is not allowed to give diuretics to patient who is hypovolemic. Hypovolemia should be corrected, then wait for the patient to void. If there is no voiding, you will give diuretics. The diuretics is a furosemide or mannitol as a single IV dose. Then weigh the result. If there is no urine output improved, you can put on the continuous infusion. If there is no response to diuretic challenge, this is challenge why? Because this is important in the management and important in diagnosis. Diuretic should be discontinued. And the fluid restriction is essential. You give a fluid, the patient not void. So here you should be cautious because the patient will undergo to fluid overload. You should restrict the fluid here. And how to give a fluid for maintenance for those patients with eovolemic. Your patient has acute kidney injury, but he is neither overload or hypovolemic. This is called eovolemic. This is calculated according to the insensible loss, which is 400 ml per square meter per 24 hour, plus the amount of fluid equal to the urine output. So that's why we put Foley catheter for the right and correct assessment of the urine output. This is for the maintenance of the patient. Electrolyte disturbances. We said there is electrolyte in form of hyperkalemia. So the hyperkalemia should be treated if the serum calcium, potassium is more than 0.6 milliequivalent per liter. I will not go to the details of hyperkalemia because you took it in the lecture of the fluid and electrolyte disturbances. The same rule followed here. Hypocalcemia. So primarily treated by lowering the serum phosphate level and may give calcium carbonate. So calcium, we will not go to give the calcium gluconate directly. Why? Because if it's given intravenously, it will lead to the calcium salt deposition into the tissue, leading to subcutaneous tissue necrosis. Unless the patient has hypocalcemic tetany, we replace with calcium gluconate. Hyponatremia, we say the hyponatremia may be delusional. So sometimes the hyponatremia, when we just correct the fluid status, so it will be corrected. There is no need to give sodium chloride. Metabolic acidosis, we say because of the retention of the hydrogen ion. In most of the cases, there is no need to treat it. The correction is by the fluid management and electrolyte. But if the arterial pH is less than 7.15 and the bicarbonate is less than 8 milliequivalent per liter, so the patient should be managed with the bicarbonate. We should infuse bicarbonate for the patient. Or it contributes to significant hyperkalemia, because hyperkalemia is also an additional bad effect on the metabolic acidosis. Patient with acute kidney injury may have GI bleeding. So H2 blocker is the management of choice, or the proton pump inhibitors. The hypertension, patient may have hypertension. So salt and water restriction, diuretics have role, and long-acting agent like the calcium channel blocker or the beta blocker. Patient may have the neurologic symptoms of the uremia, which is the disturbed level of consciousness or the seizure. So here, the use of benzodiazepam, most effective in controlling the seizure, and the therapy directed toward the precipitating cause. Why this patient has neurologic symptoms? So if the precipitating cause, it will be relieved. Patient with acute kidney injury may have anemia, but the mild anemia, it may be up 9 to 10 gram per deciliter. So there is no need to correct the anemia. Unless the HB level it is less than 7 grams, so packed RBC is recommended. Nutrition. Patient with acute kidney injury, you should meet their nutritional requirement because it is of critical importance. Leash. In most cases, the sodium, the potassium, and phosphorus should be restricted because decreasing the phosphorus leads to elevation of the calcium. The patient always, he has a hyperkalemia. The patient has a fluid overload and or hypertension, so you should restrict the salt. Protein intake should be moderately restricted, and the caloric intake should be maximized to minimize the accumulation of nitrogenous waste, because there is inability to cleared by the kidney, and sometimes we go to give the parenteral nutrition, giving amino acid intravenously through the central venous line. If there is failure of the medical management, we go to other intervention, which is the dialysis. What is the definition of dialysis? Dialysis, it is the process of removing excess water, solutes, and toxins from the blood in patients whose kidneys can no longer perform these functions naturally. This is the natural function of kidney, but now it can do it, so the dialysis will take for this. So we have two types of dialysis, either peritoneal or the hemodialysis. We start with the indications. Of course, in general, failure of medical management, we reach to the level of dialysis. So either anuria or oliguria, overload, and it is refractory to diuretic therapy. persistent hyperkalemia. When we say persistent hyperkalemia, this is meaning you try to correct it, but there is no response. Severe metabolic acidosis, unresponsive to medical treatment. Uremia, signs of uremia. Blood urea more than 100 on 150 or rapidly rising. A calcium phosphorus imbalance with failure of the other measures and inability to provide the adequate nutritional intake. All these mean failure of medical management. Going to the dialysis become indicated. So the types of dialysis, we have 3 types, which is the intermittent hemodialysis. Each type has benefit, has advantage, has contraindication or complication. So for hemodialysis, which is intermittent, this is a prevent in patients who are relatively stable hemodynamic state, because it may lead to bleeding, to hypovolemia, to thrombosis. So highly efficient to do the intermittent hemodialysis is to give 1 session in 3 to 4 hours. And the session can be repeated 3 to 7 times per week. This is meaning every day or every other day, accordingly. Complication, hypotension, bleeding, or thrombosis. So that's why it should be done in a stable hemodynamically patient. This is the hemodialysis. This is the artificial kidney. And we should give heparin to prevent the clotting and monitoring of the blood in and out. The diagram shows the principle of action of the hemodialysis. And this is the hemodialysis machine, or what's called the artificial kidney. The patient connected it through the AV fistula. The peritoneal dialysis. Peritoneal dialysis, it is another type, depend on the function of peritoneum. So it's most commonly used in infant and in neonates because the difficulty of gain an arteriovenous access for hemodialysis. And the cycle and the 1 session, it is of 45 to 60 minutes to do. And we need to repeat the cycle or the session for 8 to 24 hours per day based on the patient fluids and electrolyte balance. So it may be repeated every hour or just 8 times. The infused fluid of dialysis is 800 given through the peritoneal cavity by inserting catheter. So there is no need for anticoagulation. There is no risk of bleeding, but the complication it may cause abdominal pain and peritonitis. So if your patient suspect to have infection, you will add the super added infection by peritonitis, and peritonitis may lead to life-threatening sepsis. And of course, it is contraindicated in patients with significant abdominal pathology, obstructive uropathy, hydronephrosis, a tumor, something related to the GIT, making the insertion of the catheter inside the peritoneum is difficult. This is the peritoneal dialysis, and this is the catheter inserted in the abdomen of the baby. And the principle is the diffusion of the water and the solutes and the toxins through the peritoneal cavity, the membrane, the peritoneal membrane. It will act like the nephron in this type. We have what is called the chronic or the continuous renal replacement therapy. It is hemodialysis, but it is continuous. This is preserved for patients who are unstable hemodynamically, and this is with concomitant sepsis. So unstable hemodynamically, you can't do intermittent hemodialysis. Concomitant sepsis, you can't do the peritoneal dialysis. Or patient has multi-organ failure, like what happened now in COVID-19 critical cases. So these patients are admitted in the ICU. Here, the indication of continuous renal replacement therapy. It is extracorporeal therapy. You heard about the ECMO, the extracorporeal oxygen management, or oxygenation. Here, extracorporeal therapy regarding the kidney function. So it is always continuous, 24 hours per day, by specialized pump-driven machine, not like the machine of hemodialysis, which is the conventional. So here we should give heparin or citrate as anticoagulant. And now I reached to the end of the lecture because I can't give you the hemolytic uremic syndrome. It takes about 10 minutes and your time is finished. So just to talk about the prognosis of the acute kidney injury. The recovery depends on the etiology, on the severity, on the ability or availability of specific treatment, and other aspects of the patient course. So the recovery or the prognosis, it may be worse or it may be good. So if renal limited conditions, like in post-streptococcal nephritis, the low mortality rate, less than 1%, this means a very good or excellent prognosis. While in those related to multi-organ failure, of course, the mortality rate will be more than 90%. So the recovery is likely after the acute kidney injury. We expect it from prerenal causes because correction of the as dehydration, as we said, or acute tubular necrosis, or acute interstitial nephritis, or tumor lysis syndrome. All these have a good prognosis for the recovery. While the recovery of renal function is unusual. We didn't expect the recovery when the AKI results from most type of rapidly progressive glomerulonephritis or bilateral cortical necrosis or bilateral renal vein thrombosis. Bilateral, so affecting the kidney bilaterally. The medical management necessary for a prolonged period, even after correction of the acute kidney injury, to manage the sequelae, including the chronic renal insufficiency, the hypertension, the renal tubular acidosis, and urinary concentrating defect. Now, I reach to hemolytic uremic syndrome, but I said we have no time because we need at least 5 minutes to complete. So, ليش نتحدث عن hemolytic uremic syndrome? Because here we will talk specifically on acute kidney injury and on something related to the intrinsic, of course, and something related to the digestive system or related to the gastroenteritis or diarrhea. Acute kidney injury, by definition, it is the most common glomerular vascular cause of acute kidney injury in HUS, in the childhood, sorry. So it is intrinsic glomerular vascular, involve the glomeruli and the blood vessel inside the kidney. And it is the most common. It is characterized by triad of. What are the triad of the HUS? Microangiopathic hemolytic anemia, called MAHA, thrombocytopenia, and renal injury. So not just acute kidney injury, you have hemolytic anemia and you have a thrombocytopenia. Typically occur in children less than 5 years of age, but it can occur in older children and it can occur at any age, even in adulthood. Two types of HUS we have, which is the typical or classical, or sometimes called the D plus HUS, and we have the atypical, or called the D negative. D refer for diarrhea because the most common type, this is the most common type, and there is a prodromal diarrheal illness. And which diarrheal illness? This is the result of contamination. This is not any diarrhea or gastroenteritis. Of course, this is by E. coli and by a special strain of E. coli, which is called the E. coli O157H7. This is producing toxin called virotoxin. This is causing invasive enterocolitis, but it may be caused by Shigella, has what's called the Shiga toxin. This virotoxin produced by this certain strain of the E. coli cause hemorrhagic enterocolitis, invasive causing hemorrhagic, with variable severity, and result in HUS in 5 to 15% of affected children. This is a high ratio to cause the HUS by the hemorrhagic E. coli. The atypical, here there is no prodromal. This is less common, of course, and there is no prodromal diarrhea. It can happen at any age, even in adulthood. It can be secondary to medication, to malignancy, to pregnancy, to genetic causes, to infection like Streptococcus pneumonia or HIV. The pathophysiology. What happened in acute, in hemolytic uremic syndrome? This virotoxin causing endothelial damage. This endothelial damage lead to deposition of platelets and microvascular occlusion inside the glomeruli with subsequent hemolysis and thrombocytopenia. So this will block the function, the filtration function of the glomeruli because of the microvascular occlusion, because of a platelet deposition and subsequent hemolysis and further thrombocytopenia. This is a type of a thrombocytopenia called thrombotic because there is a thrombosis caused by the deposition of the platelet. Glomeruli, as I said, become clogged with the platelet and damaged RBC, endothelial damage. Clinical manifestations of the disease. You remember the clinical manifestation of acute kidney injury when we go to the history. So here in D plus HUS, prodrome of abdominal pain, diarrhea, especially bloody diarrhea, vomiting, dehydration is often present. Oliguria, anuria, because we say it is the hallmark of the acute kidney injury. Pallor, because there is hemolytic anemia. Bleeding manifestation because of thrombocytopenia, petechiae, purpura, principally in the GIT or in the skin in the next 7 to 10 days. Hypertension, acute kidney injury causing hypertension. And some children who have severe renal failure and the fluid overload, there is hypertension. CS involvement by seizure up to 25% of the cases. And sometimes the CNS involvement is not by the seizure because of uremia, because of the CNS bleeding, because of thrombocytopenia. Other potential involvement like the pancreatitis, heart failure or cardiac dysfunction as we written here, and colonic perforation, hemorrhagic enterocolitis leading to even perforation of the colon. So the investigation, by the history we put in our mind and by examination, this is an HUS, acute kidney injury due to HUS. So CBC important. We will find profound anemia, thrombocytopenia, leukocytosis, which is a sign of infection. Blood film reveal evidence of microangiopathic hemolytic anemia. We will see the cystocyte, helmet cell, and bar cell. This is typical of this type of an anemia. Retic count will be high because this is hemolytic anemia. But of course, the Coombs test will be negative because this is non-immune-mediated hemolytic anemia. Increase LDH because this is a marker of inflammation. Indirect bilirubin at AST. This can be increased in any inflammation. Elevated creatinine, of course, because we are talking about acute kidney injury. Presence of hematuria, proteinuria, pyuria, and cast or urine analysis. Pyuria, it means the pus cell inside the urine. We talk about bacterial enterocolitis. So stool culture for the E. coli for this special strain or for the Shigelli toxin is important to prove the diagnosis. And elevated amylase and lipase because we say the patient may have pancreatitis. This is the blood film show the schistocyte. Here is the schistocyte like this, and this is the helmet cell تشبه الخوذة, and this is the bar cell like this, and this. These are the markers or the findings in the MAHA, microangiopathic hemolytic anemia, and the hemolytic uremic syndrome. Now the treatment. This is a correctable and acute kidney injury. Volume repletion, electrolyte correction, adequate nutritional support. Antibiotic and antidiarrheal agent maybe increase the risk of developing HUS. So it should be avoided, contraindicated. Why? This is a bacterial enterocolitis. Why we didn't give antibiotic? Because antibiotic lead to more release of the virotoxin and adding more harmful effect or insult on the kidney. While the antidiarrheal, of course, will withhold the clearance of the virotoxin. Let the patient has a frequent loose bowel motion, so he will clear of the virotoxin. Control of hypertension, of course, by salt and water and fluid restriction or by the antihypertensive agent. Managing of the complication of renal insufficiency, we can go to dialysis if there is no response. And if the patient has severe anemia, so we can replace him with packed RBC transfusion if needed. And platelet transfusion should be avoided. Why? Because this is a thrombocytopenia. When we give the patient a platelet, this also will add another mass of platelet, will be aggregated, will be deposited inside the microvascular of the kidney of glomeruli and leading to worsening of the, unless there is an active bleeding. Unless there is an active bleeding, like what? Like CNS bleeding. Prognosis. Now I will finish. Most children recover from acute episodes within 2 to 3 weeks. So it is good prognosis in general. But the patient may have residual renal disease, including the hypertension. This is occurring about 30% of them. And unfortunately, 15% of them, they will have end-stage renal failure. Follow-up should be continued in the first 2 years for serial determination of the renal function and monitoring of blood pressure up to 5 years of age. The mortality comes from where? Comes from the CNS, like in CNS bleeding, or from the cardiac complications, heart failure, pulmonary edema, arrhythmia. And now I reach to the end of the lecture. So if in the above the kidneys, the adult knees will look like this. Thank you, and I'm sorry for the interruption because of